This is Pick Your Poison. I'm Dr. JP, ER doctor, toxicologist, and unapologetic lover of all things poison. Today's episode is about a toxin so powerful that a little smeared on the tip of a blowgun arrow is enough to silence every muscle in your body, including your diaphragm, stopping your breathing. How did a poison like this become a commonly used drug in modern medicine? We'll also go inside a Siberian prison cell where one of the most high-profile political prisoners on the planet collapses and dies. Was this a state-sponsored assassination using a poison from the rainforest? Stay right here to find out. This is an interactive story. Survival isn't guaranteed. What happens next depends on you. So, time to get your gloves on. It's 8 p.m. The Natural History Museum is closed. It's dark and silent, except for you, because tonight you're living a childhood dream. Your friend, a museum curator, has let you in after hours. He's an ethnobotanist studying how plants were used in ancient cultures for medicine, ritual, and sometimes poison. He's working on a new exhibit called Medicine from the Amazon. You're there with him behind the scenes. You've seen woven baskets still dusted with traces of crushed plants, ceremonial tools used by shamans, and skulls with perfectly carved holes drilled into them from ancient brain surgery. Your favorite part so far? Images of poison dart frogs, tiny, brightly colored, beautiful, and toxic. You learn some new facts to share with your residents during your next lecture. Across the room, your friend speaks with a colleague discussing final details like labels and lighting. He turns back to you and says, "Ready for dinner?" Your stomach growls in response. There's no food allowed in the museum, and you're definitely ready. "Let me grab my bag from the back," he says. His colleague wants to finish up some other work, but will join you in an hour. Your friend returns, bag over his shoulder. He rubs his hand absently for a moment before buttoning his coat. You step out into the sharp winter air. The restaurant is only a block away. It's warm and cozy inside. The waitress recognizes him immediately and seats you at his regular table. He struggles slightly with his coat buttons before pulling it off and draping it over the back of his chair. He rubs his forehead. "Whew, I'm exhausted. This exhibit is taking it out of me." You smile. It's going to be incredible. You notice a small smear of red on his hand and point it out. Blood. He looks down. "Scratched it, grabbing my bag. It's nothing." The waitress appears. "The usual?" she asks. "Gin and tonic? Burger?" You say you'll take the same. The drinks arrive quickly, and you talk about opening night plans and media coverage. He props his head on his hand again. "Wow, I am really tired." In the museum, he was energized and animated. Now he looks pale and drained. "Just tired, you ask?" "Kind of dizzy. My mouth is dry." He tips back the rest of his drink. Then he slumps sideways in his chair. You catch him before he hits the floor. A man from the next table helps you hold him up. The waitress calls 911. You can't do much else here in the restaurant but hold him up. What's happening? He was fine 30 minutes ago in the museum. Fortunately, EMS arrives quickly and transports him to the emergency department. This is fiction, so of course, you're the doctor. The nurses get him undressed and into a gown and on the monitor. His vital signs are as follows: 98.6 Fahrenheit or 37 Celsius, heart rate 110 beats per minute, blood pressure 100 over 50, respiratory rate is 6, oxygen saturation is 91% on room air. On exam, he's awake and looking at you. He's having difficulty speaking but appears to understand what you're saying. He manages to convey he feels very dizzy. His limbs feel heavy and hard to move. He also feels short of breath. On exam, his cranial nerves are intact, meaning he's able to move his eyes, wrinkle his forehead, and smile. His respiratory rate is low, as noted on the vital signs. There's poor excursion of his chest wall, meaning it's not expanding with his breaths, but his lungs are clear to auscultation. His heart rate is a little fast, but otherwise unremarkable. There's no abdominal tenderness. His extremities are significantly weak. He's able to move them, all 4 limbs, but minimally. You ask him to hold up his right arm. He moves it on the bed, but can't pick it up. You pick it up for him, and it thuds back against the bed, meaning he can't hold it against gravity. Uh-oh, this is pretty worrisome. He's developed significant muscle weakness in less than an hour. 30 minutes ago, you were leaving the museum, and he didn't have difficulty walking to the restaurant, meaning he was intact at that point. Question number 1, what's the first step? A, obtain more history. B, activate the stroke team. C, intubate him. The answer is C. In sick patients, as you know, we start with the ABCs, and his breathing is at risk. Not only are his extremities weak, his low respiratory rate and poor chest wall movement mean his diaphragm is affected as well. He needs to be intubated before this rapidly progressive weakness leads to complete respiratory failure. The weakness is already reflected in his low oxygen saturation. I personally wouldn't waste any more time, and I'd call for RSI meds or rapid sequence intubation drugs to get him intubated before the situation becomes worse. You tell him you're concerned about his breathing and you think he needs to be intubated and put on a ventilator to treat it. His eyes widen and you can see he's trying to ask you what's happening, but he isn't able to say very much. The monitor starts beeping. His oxygen saturation is now 89%. This is unfolding quickly, just as you predicted. There are all sorts of cocktails for RSI meds with pluses and minuses to each of the drugs. In general, we use a sedative plus a paralytic. There are important exceptions, but most of the time, the best way to get the tube through the vocal cords into the trachea is when the patient is both paralyzed and sedated. You order your favorite cocktail, rocuronium, and etomidate. You tell the nurse the dose to administer, then get your friend intubated and on the ventilator. You order some basic labs, a chest x-ray to check his lungs, as well as the placement of your breathing tube and EKG. You also order a sedative drip to keep him asleep while the breathing tube is in place. It's not a good feeling to wake up with a plastic tube jammed down your throat. Okay, it's time to take a few deep breaths yourself. This unfolded extremely rapidly. Now your job is to try to figure out what the heck happened. Despite what you ordered, it's really doubtful the answer is in the labs or the chest x-ray. I hate to say it. You don't know everything about your friend's past medical history. You do know he was fine an hour ago. Essentially, he developed bilateral, rapidly progressive paralysis. Could this be a stroke or an intracranial hemorrhage? Pretty unlikely. Those present with unilateral, one-sided symptoms. A head CT is certainly a good idea, but more as a precaution than a definite answer in this case. Could he suddenly have developed myasthenia gravis? You've probably heard of this. It's a rare and unusual disease where the body produces antibodies against itself for elements of the neuromuscular junction. These antibodies keep the muscles from working, resulting in weakness. It's not impossible this is the myasthenic crisis, but the typical history is weakness that comes and goes, and interestingly enough, it's usually worse in the afternoon after the muscles become fatigued. Neurology will probably consider this, but your friend hasn't had weakness before, so it's pretty unlikely. We've talked about tick paralysis with a bite injecting toxins causing weakness. It can have a fairly rapid onset, though it's usually ascending in nature. In addition, the Natural History Museum isn't out in the countryside, but downtown in a city. Maybe a tick crawled out of one of the exhibits, but doesn't seem very likely. We talked recently about magnesium. It can cause a rapid onset of weakness. But your friend would have had to have been eating Epsom salts for dinner or getting an IV infusion of magnesium while at the museum, so it doesn't fit. There is one electrolyte disturbance causing dramatic onset of paralysis. That's question number 2. Is it A, calcium, B, potassium, or C, chloride? The answer is B, potassium. There is something called periodic paralysis, which occurs with dramatic fluctuations in potassium. It's a very rare disease. It can be hereditary. Essentially, patients have dramatic fluctuations in potassium, either high or low, and it causes muscle weakness and paralysis. It can be triggered by stress. Maybe the stress of the exhibit opening caused this. His potassium level is pending, so we'll see. But as you know, this is a toxicology podcast, not a neurology one. So let's focus on poisons. Botulism, we talked about both infant and foodborne types. Obviously, it causes weakness. Is this botulism toxicity? Well, the onset is actually too rapid. Botulism is fast, but symptoms develop over 12 hours, often more like 24 hours, not minutes. And with infant botulism, it's days to even weeks. Botulism causes descending paralysis, and our patient seems to have become weak all over, all at once. Same with Guillain-Barré syndrome, not caused by a toxin, but always on the differential for paralysis. None of these answers feel particularly satisfying. His results come back, his head CT is normal, his chest x-ray, including your breathing tube, look fine, the tube is in good position, his labs are normal, including potassium and magnesium. You consult neurology, who recommends more tests, including an MRI, but the neurology team doesn't seem to be particularly confident about the diagnosis either. The nurse wants to know if a visitor can come back. A visitor, you ask? You haven't even had a chance to find info to contact his family. Sure, you say. A man enters the room. You recognize him as the colleague your friend spoke to just before you left the museum. You'd completely forgotten he was supposed to meet you at the restaurant. He stares in shock at your friend, sedated, hooked up to tubes and wires and on the ventilator. The man says he finished working, went to the restaurant, heard about the commotion that had happened, realized it was his colleague, and came straight to the emergency department. You ask if your friend had been complaining of any medical problems lately or reported any issues. He says no, everyone involved in the exhibit was tired given the heavy workload and the long hours, but it was offset by the excitement of digging through archives to find special pieces. He asks what happened. He was fine at the museum. You explain about onset of rapid paralysis, but that the etiology of this is unclear. He has a surprised expression and then raises an eyebrow. Paralysis, he says? You nod. Paralysis, like he can't move his arms and legs? Yes, exactly, you say, in the time it took to walk 1 block. He says, do you think it was the arrows? The arrows? You'd have noticed if your friend was shot with an arrow on the way to dinner, not to mention you'd have had to dig it out once he got to the ER. Part of the exhibit, it's poisoned arrowheads. You know, Amazon plant to modern pharmacology. He pauses to see if you're following. You aren't. I had the poisoned arrowheads on the workbench to label them for the exhibit. Do you think he could have touched one? Accidentally? Now you are following. This was not on your differential and not on neurology's either. At the restaurant, you noticed a tiny spot of blood on his hand. Your friend said it was a scratch. Perhaps a poisoned arrow? What kind of poison, you ask? I don't know, it could be anything, he says. What? What kind of museum is this? They don't know what they have? He sees your frown and says, I had about 30 different types of arrows out on the table deciding which to include in working on the labels. How old are they, you ask? Would any poison still be present? Would it still be biologically active? Could one have caused your friend's symptoms? Some are hundreds of years old and others are newer, collected by museum staff on trips to the Amazon and other locations. Your brain is racing with questions, but let's start with first things first. What kind of poisons are on poison arrows? It's a really fascinating topic, in my opinion, showing the ingenuity and depth of pharmacologic knowledge present in ancient times. Question number 3. Toxins from which of the following have been used as arrow poisons? A. Plants, B. Insects, C. Snakes, or D. All of the above? The answer is D. All of the above. One of the oldest arrows found by archaeologists in South Africa had residue from a plant called the Bushman's poison bulb, a plant with beautiful pink flowers. These arrows, if you can believe it, are 60,000 years old. Bushman's bulb is toxic to animals, and humans it could cause some eye irritation, some headaches, and it may cause hallucinations. But we've been using poison arrows for at least 60,000 years, really mind-boggling. Snake venom has been used to poison arrows. This was famously encountered by Alexander the Great and his army in 325 BCE when fighting the Harmatelians in India, now part of Pakistan, on swords and arrows. Some have suggested that this was cobra venom, but modern historians believe it was Russell's viper venom because it fits more closely with the descriptions of death. Victims became numb, but also experienced pain and convulsions. Wounds became gangrenous, and the victims died a very painful death. Beetles are used, also in Africa. The larvae are poisonous, but not the mature beetles. Symptoms develop over days, not hours, though, in this case, and the primary mechanism seems to be red blood cell hemolysis. When red blood cells break down, the body can no longer carry oxygen, resulting in death. What about poison dart frogs? This is a very timely question for reasons I'll come back to in just a second. Several toxic compounds are found in poison dart frogs. 2 of them are batrachatoxin and epibadidine. Batrachatoxin causes paralysis and cardiac arrhythmias. You ask if any of the arrows were poisoned with poison dart frogs. He said no, those were already in a display case to be definitely used. Now, epibadidine I want to talk about because it's extremely timely, and this news came out coincidentally while I was preparing the podcast. If you're a listener, you know a lot about Russians and poisons, and it's believed Alexei Navalny, the Russian dissident, developed organophosphate toxicity from poison underwear. We talked about that before. After returning to Russia, he was eventually imprisoned, and he died in prison a year ago in February 2024. According to Russian accounts, Navalny took a walk inside the penal colony, then collapsed and died and was unable to be revived from cardiac arrest. The prison reported that he died from, quote, sudden death syndrome, end quote. I mean, it's just astonishing, that term, which is undoubtedly true and also conveys completely useless information at the same time. But what's interesting is that recent analysis of his blood, analyzed in Europe, showed the presence of epibadidine. This compound is found in poison dart frogs in Ecuador and Peru. It's not actually produced in frogs living in captivity. They have to be in the wild. It's a neurotoxin causing paralysis and respiratory failure. In addition, actually analgesia is thought to be 200 times more potent than morphine. Anyway, several European countries concluded that Navalny was murdered by the Russians with epibadidine based on this evidence. An ex-Russian scientist suggested it would have been made in a lab, probably rather than gathered from frogs in the wild. This could fit with our friend's poisoning, but the other curator is clear that the arrows with poison dart frog toxicity had already been separated. Tons and tons of other stuff can be used as arrow poisons. We could spend all day here. We've touched on some things in other episodes, including digoxin, a cardiac medicine and a toxin in high doses, strychnine, aconidine. The list really does go on for forever. But we haven't mentioned the classic poisoned arrow toxicity that causes paralysis. It's question number 4, and it's time to pick your poison. Is it A, tetrodotoxin, B, tetanus toxin, or C, curare? The answer is C, curare. All of the above do cause flaccid paralysis, but it's curare that's classically associated with arrows from the Amazon. Now, I'm probably going to mispronounce this, but the word curare originates from the word urare, an indigenous word from Guyana, meaning arrow poison, and further derived from two words put together meaning bird and kill. One of the reasons curare is used as an arrow poison is that it doesn't cause toxicity if it's ingested. So, if you use it during hunting, people eating the animal don't have a risk of toxicity. It's inactivated in the stomach, and it has to be injected to cause toxicity. Death from a curare poisoned arrow would be a bad way to go. Curare doesn't cross the blood-brain barrier, meaning you're fully awake, paralyzed, and unable to move or speak until you die of respiratory failure. No, thank you. Curare is made from vines found in the Amazon. There are dozens of different kinds. They're often chondrodendron and strychnos species. The stems and the bark are boiled down into a thick paste, and then it's applied to the arrow tips. The active ingredient is actually D-turbocurarine, and this was the first paralytic used in surgery in 1942 in Canada. Anesthesia had at this time been around for about 100 years. When patients were asleep, when surgeons cut into the muscles sometimes spasmed. This could be treated with higher doses of anesthesia. It did help with the muscle spasm, but sometimes it killed the patients. So for this reason, the abdomen could be very difficult to close at the end of a procedure because the muscles were spasming and difficult to suture. Curare was first used in an appendectomy, preventing the abdominal muscles from spasming and allowing easy closure of the wound. It was also used during ECT or electroshock therapy to prevent broken bones and joint dislocations with the electrical shocks. And we actually still today frequently use paralytics in the ER for intubation. They're sometimes used in the ICU for paralysis. Anesthesia uses them still in the operating room. These days we use derivatives of curare like rocuronium and vecuronium. Uh-oh. During intubation we gave him rocuronium. We gave a paralytic to an already paralyzed patient. Did we make him worse? Well, fortunately no, because we intubated him, so no harm was done. How does curare work? It binds to acetylcholine receptors in the neuromuscular junction. It blocks acetylcholine, meaning the muscles can't contract, resulting in flaccid paralysis. Question number 5. Is there an antidote for curare? A, yes. B, no. The answer is A. Technically, yes, there is. We can give physostigmine, the antidote for anticholinergic toxicity, but I probably wouldn't give it even if I had known before we intubated him what he'd been poisoned with. Why not? Well, first, a quick reminder about how muscles work. An impulse from the nerve causes release of acetylcholine into the neuromuscular junction. Acetylcholine crosses over, it binds to the muscle cell membrane, it causes depolarization, and the muscle cell contracts. So curare binds to nicotinic receptors, where acetylcholine is supposed to bind. It therefore blocks the signal, the muscle can't contract, and it causes flaccid paralysis. Physostigmine is a cholinesterase inhibitor, meaning increased acetylcholine, meaning increased muscle contraction. What's the dose of physostigmine to reverse curare? I have no idea. What are the side effects? Physostigmine causes cholinergic effects, including nausea, vomiting, diarrhea, and the killer bees, i.e., bradycardia, slow heart rate, bronchospasm, and bronchorrhea or fluid in the lungs. Physostigmine is toxic in and of itself. If you remember, it's naturally occurring in the calabar bean, and it's been used as a trial bean in the past for witchcraft trials. I have no idea of the physostigmine dose for curare overdose because, of course, we have no idea the amount of curare exposure. There's probably somebody out there arguing for physostigmine before intubation, but I'm picturing trying to calibrate physostigmine to the right dose and seesawing back and forth between curare toxicity and physostigmine toxicity. Intubation is much safer and it's guaranteed to work until the curare wears off. Modern-day paralytics used in the operating room have a modern antidote frequently used by anesthesia at the end of an operation. It's called Shigamidex, and it reverses several paralytics. Interestingly, it has a donut shape, and once you give it, it holds vecuronium and pancuronium inside, inactivating them. All right, so back to our patient. His colleague agrees several of the arrows were tipped with curare. By intubating our friend and putting him on the ventilator, we've safely treated him until the curare wears off. How long will it last? Well, it's a really quick-on, quick-off drug, one of the reasons it was popular in medicine. It can last for as short as actually 20 to 30 minutes. You speak to the intensivist. She says she'll leave the sedation on for a total of 2 hours to avoid the risk of having him paralyzed but awake, then come to the ED to assess him. I have to share this crazy story I came across during research for this episode about a plot to kill Lloyd George, the British Prime Minister during World War I, with curare. A family of conscientious objectors, one of whom owned a chemist shop, decided to try to assassinate him using curare. Unbeknownst to the family, a government spy infiltrated the plan. In fact, the spy was given the job of shooting Lloyd George on a golf course with an airgun containing curare pellets. It was a crazy plan, and fortunately it was stopped by the authorities prior to any attempt. A few hours later, the intensivist comes down, turns off the sedation, and re-examines your friend. He's awake and moving. She decides he meets extubation criteria and extubates him, taking the breathing tube out in the emergency department. He not only recovers without sequelae, he doesn't even get admitted to the hospital, but gets discharged after a period of observation. He says his hand brushed against something sharp while grabbing his bag. Hungry, he dismissed it as a small scratch, not realizing a poison arrow was the culprit. This is a fictional case, but it is based on real poisonings, particularly one published by a curator at the New York Botanical Garden who accidentally stabbed himself with a curare dart while cleaning out his personal collection. How do we know this? He published the account in a medical journal. The last question in today's podcast. Curare has been used to treat which other poisons? A, strychnine, B, tetanus, C, rabies, or D, all of the above? Follow the Twitter and Instagram feeds, both at PickPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Until next time, take care and stay safe.